Okay, I think we're back. Hi, everybody. Welcome back to the Practicum 2 certification review sessions. If you don't remember me, my name is Miss Bree. I'm going to be your instructor for the certification review sessions. I'm going to go ahead and put myself in presenter mode so that we can get started. Okay, hopefully everybody can see this. I'm going to actually put it into presentation mode. So exactly right. Welcome back. We are in certification review session 1 for Practicum 2. As always, we are going to have a packet to accompany the certification review session. Please download and either print out this certification review worksheet or have it available on a tablet or another device so that you can do the questions on your own and follow along with us. The worksheet is available on Blackboard under the Student Resources folder. Under the Certification Review Sessions folder, you will find the Practicum 2 Certification Review Session 1 questions. So please have those available and ready before you get started on the rest of the recording. And just as a reminder, we are implementing our test taking strategies. Hopefully, this has been in practice now in other study sessions that you are hopefully doing on your own with review questions, the practice tests that we've been doing together, board vitals. Hopefully, the test taking strategies are proving to be effective. And I want you to stick to them because the consistency is going to be beneficial and keeping you honest in how you're answering these questions. So I'm going to go through them again. I know I sound like a broken record, but we're going to talk about steps 1 through 4 and why they're important. So step number 1 is to read the question in its entirety. You need to physically read the entire question. I know we have a tendency as human beings to try to rush through everything, but I want to make sure that you completely digest what you've read as far as the question is concerned. So read the question in its entirety, close your eyes, take a deep breath, make sure you've really digested what it's asking. Don't look at A, B, C, and D yet. Please do your best to refrain from that until you have gone through steps 1 and 2. So once you've read that question in its entirety, before you read it again, I want you to take this time as you're taking your deep breath to really think about it and try to answer it in your head without looking through A, B, C, and D. And that's going to be important when it comes to the later portion of the test taking strategy. So try to answer it in your head, think it through, make sure you've read it fully once, and then you're going to do it again. So step 2 is you're going to read the question once more. This is so that we can identify any portions of the question that we may have misinterpreted, misunderstood, misread. We're human beings, we can make mistakes. Reading it once is great. Reading it twice is even better. That way you can identify maybe some key words that are in the question that can help you answer this question to the best of your abilities, especially those key words like everything is true except this is the most ideal strategy. You need to understand what those keywords are trying to ask you because there might be more than one correct answer. You need to look for the best answer based on the information provided to you in that question. So make sure you identify those keywords when you read the question the second time. Now you can look at A, B, C, and D. Now, step 3, you can discard those 2 options from your A, B, C, and D question bank. This is going to be helpful in process of elimination, getting it down to a 50-50. Statistically, this is going to improve your chances of potentially answering the question correctly. Because if you can at least identify 2 answers that are totally incorrect, even if you're guessing, you're getting statistically a higher chance of guessing correctly. You're going from a 25% chance of guessing correctly out of A, B, C, and D, because 1 out of 4 chance. If you eliminate at least 2 of the options, even if you eliminate 1 of the options, you're statistically getting yourself into a better position to answer it correctly or guess correctly. So do your best to discard at least 2 options from your A, B, C, and D and get down to that 50-50. Okay. And the last step is to answer the question with confidence. This is something that took me a long time to learn. I'm sure I'm not the only one. If you had answered it in your head, step one, when you were thinking it through, if you've got that same answer choice available in your A, B, C, and D, hopefully your 50-50 that you've narrowed it down to, go with your gut. Your gut was trying to tell you something. You want to say you're going with your heart or going with your mind? Great. I don't care which body part you use in answering with confidence, but my point is if you were able to digest the question, think it through in your head, and answer it before even looking at A, B, C, and D, I would say that that is a strong sign that you had the correct answer, right? Or at least this way you can go to sleep at night knowing that you did everything in your power and trusted your gut to get it correct. So make your best educated guess if you weren't able to answer it in your head properly during step one in the test taking strategies. If you didn't have an answer, you narrowed it down to a 50-50, take your best educated guess. Go with your gut. And something we didn't really talk about in Practicum 1 that I do really want to make sure you guys understand in Practicum 2 when we're implementing the test taking strategies is that going with your best educated guess here is going to matter. I like to say it's book versus reality. You might have seen some techniques in the clinical setting that were not the exact same or identical as to what is in the textbook. The textbook is what the test is written based off of, not on the clinical setting. So obviously, everyone is going to have their own experience in the clinical setting, but if you have two potential answers in your 50-50 and you're like, well, I read this in the book, option one in the book, but I saw option two in real life. Go with the book. That is what this exam is based off of, is the, I guess, practice standards, if you will, the best techniques, the most peer-reviewed scientific evidence in sterile technique and surgical procedures. So if you read it in the book and the other option you have is something that you saw in clinical, go with the book. Trust me, okay? And then don't go back and change your answer. The only reason that you should change your answer is if you had, answered it maybe 30, 40 questions ago and you have this epiphany moment that you either read the question wrong or you misremembered something. You shouldn't be constantly going back and changing your answers. Don't second guess yourself unless you have kind of this epiphany, this aha moment. I actually have had this maybe once in my life where, question one was talking about a general surgery procedure and I answered it and I went on to, question 50 and it was talking about a similar thing and it kind of jostled my memory. I went back and reviewed. I still do your test taking strategies. Okay. If you're not 100% certain, if you have this epiphany moment and you want to go back to question one in my hypothetical scenario, do your test taking strategies again. Okay. That's the only reason that you should ever go back and change an answer. If you have this understanding that, oh my gosh, I think I read that question wrong. I need to go back and do it again. So that's the only reason. Please refrain from doing that as much as possible because you're going to regret it. Okay, that was a really long-winded test taking strategies review. I am anything if not brief. So I'm going to continue on in our learning objectives. We are in Practicum 2. The last time we were together, we were in ENT. So we're moving on to plastic and reconstructive surgery today. So we're going to do the anatomy and physiology, the intraoperative procedures when it comes to plastics, and then we're going to move on to just some general intraoperative procedures questions. Okay, so starting with the A and P review. Question number one, we're going to do together. I'm going to get out of presenter mode. I'm going to blow it up so we can do our test taking strategies together. So the question is, which layer of the epidermis is the most superficial? So before I even look at A, B, C, and D, and I'm even just gonna put my hand up so I can't see A, B, C, and D. So which layer of the epidermis is the most superficial? So picking apart this question, I'm going to start thinking about the epidermis and what is it. So the epidermis is physically the outermost layer of the skin. And it is, again, I'm putting myself back in the classroom to remember kind of bits and pieces. Hopefully you guys do that too. Put yourself back in your seats in the lecture, in the classroom when you guys were talking about plastic and reconstructive surgery, or if the lecture series wasn't particularly memorable or your memory is a little hazy there, try to put yourself back in where you were studying. Like maybe it was in your office, in your bedroom, in the library, wherever you had the textbook open. Try to put yourself back in that space. That'll help you start to pull some of this information back into your focus. So when we were talking about the plastic and reconstructive surgery chapter, we talked about the epidermis pretty much right away. And what the epidermis is the outermost layer of the integumentary system, which is the system of the skin, hair, and nails, and all of its, additional components like the oil, the sweat, all of that stuff. So when we're talking about the epidermis, there are 5 layers of the epidermis. And the way that I remember it, I have a little, I believe it's called a mnemonic device. Come on, let's go somewhere great. That is how I remembered the layers of the epidermis. Comment in the comment section below if you have another way of remembering the 5 layers of the epidermis, if you have your own device or your own method of remembering the layers. But the way that I remember it is, come on, let's go somewhere great. Hopefully you guys remember that if you were one of my students, but that mnemonic device is from most superficial to deep. And in the question, it asks, which is the most superficial? And if you remember in our discussion on the differences between, lateral and medial, inferior versus superior, superficial versus deep. Superficial is the outermost layer, and the deepest is going to be the innermost layer. So the most superficial is going to be literally physically I keep touching my hand. That's the closest skin I have. But the physical area that you can touch, that is going to be what layer we're looking for the epidermis. So I'm going to use my test taking strategies and try to remember my mnemonic device. Even if you didn't have the mnemonic device, you can start to think about some of the ways that these layers are named. That also helps. So we have, if I have to, before I look at A, B, C, and D, come on, let's go somewhere great. So it has to start with a C. That's my guess because come on, let's go somewhere great. So I'm gonna at least, if I can't even remember the name of it, I know it starts with the C, so that should help me. So I'm gonna look at A, B, C, and D. And right off the bat, we start with stratum corneum, which is a C for my mnemonic device. Come on, let's go somewhere great. So I'm gonna keep that on my board. Stratum germinativum is B, stratum lucidum is C, and stratum spinosum is D. So the other way that I remember, which is the deepest layer, is that it's like the germ layer essentially being kind of like the base layer, which is another word for the stratum germinativum, is the stratum. It's, I believe, Latin, basale, Basale, but I call it the base layer. That helps me kind of remember which is deepest. So I'm going to get rid of stratum germinativum because it's the germ layer or the base layer. And I know that's the deepest. So that's kind of the opposite of what we're looking for because we're looking for the most superficial. And then we have stratum lucidum and stratum spinosum. So great. Spinosum is going to be deeper as well, according to my mnemonic device. So I'm going to get rid of stratum spinosum as well. And based on going with my gut, based on, being able to answer it in my head earlier, having kind of that access to remembering all of my layers with my mnemonic device, I'm gonna stick with what I know. And I'm gonna stick with a stratum corneum. And it is correct. So I'm gonna put this back into presentation mode so you guys can see. Okay, so the layers of the skin, like I said, I think even in my mnemonic device, You can say somewhere good or somewhere great. I don't care what the mnemonic device is. But the layers of the skin are stratum corneum, stratum lucidium, stratum granulosum, stratum spinosum, and stratum basale. So come on, let's go somewhere great. The reason it's stratum basale here is because, like I discussed earlier, germinativum and basale are literally uh, two ways to say the same thing. Okay, so you might see germinativum or you might see basale, but if you know the germ layer is the base, you'll remember that those words mean the same thing. So our answer here is A, stratum corneum, and we have the 5 layers of the epidermis from superficial to deep is corneum, lucidum, granulosum, spinosum, basale. Okay, so please. There we go. Sorry, technical difficulties with my computer. Okay, so it is now your turn to implement these test-taking strategies on your own. So when I say pause, please hit the pause button on your video player, answer numbers 2 through 15 on your own. When you have completed those questions on your own using the test-taking strategies, go ahead and press play, and we will go through the answers together as a group. Okay, so on the count of 3, 1, 2, 3, pause. Welcome back. Okay, so we're going to go through this. I'm going to try to do as much explanation per question as possible, but I don't want to, have this be a 3-hour video because I could talk for that long. So we're going to go through these with a little bit of pep in our step. So number 2, patient with traumatic burn presents with a dry, waxy wound with areas of exposed muscle and eschars. According to your knowledge, the patient has suffered from which burn classification? So I know the eschars are specific to 3rd-degree burns. If you remember, superficial 1st-degree burns just have a little bit of redness and irritation. Partial thickness 2nd-degree burns and full thickness 2nd-degree burns, they are in similar categories. They have similar presentations. 2nd-degree burns are characterized a lot by blistering. So the difference between partial thickness 2nd-degree and full thickness 2nd-degree is the amount of dermis that is injured. The way I kind of look at 1st, 2nd, and 3rd-degree, and I believe I have an image and kind of a chart that I'm going to talk you guys through. So I'm going to move ahead just so you guys can see this. 1st-degree burns, I'm going to use my cursor. 1st-degree burns, this is how I remember it, only affect one layer. I know the epidermis is 5 layers. Stay with me. But one of these 3 sections of the integumentary system. When I say layer, I mean like the epidermis, dermis, and then the hypodermis, or also called the subcutaneous fat. So 1st-degree burns only affect one of those 3. That only affects the epidermis. Okay, so 1st-degree, one of the layers of the integumentary system. I know the epidermis is 5 layers. We just talked about it, but stay with me. 1st-degree, only one out of the 3 sections that we're talking about of the skin, and that's the epidermis. So that's 1st-degree burns, one thing, epidermis. 2nd-degree burns, 2 things, epidermis and dermis. You see where I'm going with this? So I kind of use the numbers to help me out. The difference between partial thickness and full thickness 2nd-degree burns, we didn't talk about it. There are 5 layers of the epidermis. There are 2 layers of the dermis. Okay, so with a partial thickness 2nd-degree burn, it's only affecting half of the dermis or part of the dermis. That's why it's called partial thickness. Full thickness 2nd-degree burn is going to affect all of the epidermis and all of the dermis. Make sense? And then 3rd-degree burn is going to affect 3 things, the epidermis, the dermis, and the hypodermis, or the subcutaneous fat. That can also go deeper. It can go into the muscles, the bone even. So that's going to be 3rd-degree. So 3 or more, technically speaking, is going to be 3rd-degree. But use your numbers. That'll help. 1st-degree, 1 thing, the epidermis. 2nd-degree, 2 things, the epidermis and the dermis. Third degree, three things: the epidermis, the dermis, and the hypodermis. And then the burn classifications and the wound appearance do come up on the certification exam. So just remember the, I guess, characteristics or the wound appearance when you are studying burn classifications because it does come up. Um, Again, first degree is just a little bit of redness, irritation, maybe a tiny bit of swelling. Second degree is mostly blistering. Second degree, blisters. Okay. Third degree is going to be those eschars, white, leathery, charred, no pain because it's burned through those nerves. Okay. Okay. During an open rhinoplasty, the surgeon may harvest costal cartilage from which structure? Costal, C-O-S-T, cost O is the prefix for the med term of the ribs. So that was a little clue in there. And this is where we're going to harvest it from, usually from the 8th or 9th rib. And we're going to use some of that cartilage to help reconstruct the nose, some of the features of the internal nose. Number 4, during an abdominoplasty, the surgeon will utilize a heavy PDS suture to perform a plication down the entire linea alba. This plication will approximate so if you remember the linea alba and the muscles of the abdominal wall, the linea alba runs down the 6-pack. If they're really ripped, they're an 8-pack, whatever you want to explain it as, but that's the linea alba is going to be that white line that goes down the 6-pack, which is the layman's terms for the rectus abdominis muscles. And the reason that we're doing this plication suture, word plication essentially means to like almost fold and suture the planes together. And the best way I can explain it, if you've ever seen a corset, I don't, I'm probably pronouncing that weird, but the plication is essentially an internal corset that we are going to utilize to reapproximate the rectus abdominis muscles, the 6-pack muscles back together. Mostly, an abdominoplasty is indicated for laxity in the abdominal wall region. Usually it's in the lower abdominal wall underneath the umbilicus, likely due to a patient having laxity in that area from a previous pregnancy that was carried to full term, maybe even multiple pregnancies. It can also be indicated for patients who experienced significant weight loss and their abdominal wall muscles have, laxed or weakened because it was carrying a lot of heavy adipose tissue. So it's usually one of those two things. It's usually because of significant weight loss or previous pregnancy. And I'm going to show you what this looks like. So the indication for the rectus muscles pulling apart, that is known as a diastasis recti. And it's called a diastasis recti because the rectus muscles have literally pulled apart. Di means two, so pulled apart like that. So what we're doing, you can see the normal abdominal wall looks like this. After a patient, for example, experiences a full-term pregnancy, and they're no longer expecting to have any future pregnancies, this diastasis might not snap back together again. Some humans do snap back after full-term pregnancy, and that's amazing, but not everybody is built that way. So this diastasis recti kind of just stays that way unless they undergo a surgical intervention like an abdominoplasty. So this is what the plication suture looks like to correct for the diastasis rectus. It literally looks like an internal corset or a zipper. So that's what a plication is. Number 5, you are the ST scrubbed into a malar augmentation surgery. Which body parts are you augmenting? Malar is another word for the zygomatic bone, which is your cheeks. And that is where we would put the prosthetic. Number 6, the sudoriferous glands, they produce oil. Oh my word, my brain is so broken. This is why I need to do my test taking strategies 1,000 times. Hi, sometimes I can be wrong. This is what happens if you actually go too fast. You know what? I'm keeping this in. I'm not even editing this out. You guys need to be here for this because if I go too fast, my brain goes the opposite direction. What are they called? God bless America. Oil glands, oil glands, sebaceous glands. There we go. This is why we have to go slow, because they both start with S. They both end in OUS. It does get tricky. So the sudoriferous glands, here we go, Bree. Let's get back on track. Sudoriferous glands, like the eccrine glands or the apocrine glands, those are sweat glands, and they appear in different places. Usually the apocrine sweat glands are in areas that smell the most. It's usually in areas of the groin or the armpits. Mainly will express sweat due to hormonal changes. The eccrine sweat glands are going to open directly onto the skin. Oh, I should have mentioned the apocrine sweat glands. The reason that they smell is because they are attached to hair follicles. And you know what else is attached to hair follicles? Oil glands. And oil can harbor bacteria. That's why the areas of the armpits or the groins with that kind of hair and that sweat mixed together, that's why it can produce something like body odor. So the eccrine sweat glands kind of open just directly onto the surface of the skin. They're not associated with hair follicles at all. Those are two types of sudoriferous glands. There is a third type, a specialized type of sudoriferous glands, which is called the ceruminous glands, and they actually produce earwax. Yes, they are technically a sweat gland, the glands that create earwax. Fun fact. But again, I'm not going to edit that out. This is a good learning lesson for you guys to see me in action and seeing why even the instructor needs to slow down and use the test taking strategies. I'm okay to be wrong. That would have happened to me on the certification exam had I not done my test taking strategies. So let that be a lesson to the whole group. Okay, let's go slower, Brie. Which skin lesion is the most harmful? This is a tricky question, potentially, because they can all be harmful. But the most harmful cancer is something that's going to travel throughout the body. And the word malignancy means that the cancer can travel throughout the body from its area of origin to other areas through usually the bloodstream. So malignant melanoma is going to be the most harmful here. You can kind of see how malignant melanoma will go deep through the layers and into the bloodstream. That's why it's the most harmful. Number 8, the system used to estimate body surface area burned in an adult patient is called. So this is the biggest key here is an adult patient, because 2 of these are systems used to estimate body surface. The Bard-Parker system is not it. That is how we classify blades. 10 blade, 11 blade, 12 blade, 15 blade, those are Bard-Parker. And then the rule of fives is out because that is how we inject for breast cancer biopsies and sentinel lymph node biopsies. If we're injecting methylene blue or technetium-99, we would follow the rule of fives. So we're down to the Brower and Lund system and the rule of nines. Brower and Lund is for kids. Rule of 9 is for adults. That is why. So this is the rule of nines for an adult patient. Remember these numbers because you never know if this is going to come up on certification. This is the Brower and Lund method. I've never seen it come up on certification where you had to use these numbers to calculate anything, but just know what the Brower and Lund method is, because children are obviously growing and are in various states of growth if they encounter a burn injury. So that's why they have a different way to calculate estimated burn area than an adult. Okay, number 9, a brow lift may be performed to treat eyebrow ptosis. Ptosis, yes, I know it says a P in front of it. Just pretend that P isn't there. It's ptosis. Ptosis means sagging, drooping, laxity. So C is our answer here. Number 10, which of the following is classified as a free graft? Pedicle is not free, so that's gone. A skate is not free, that is gone. Tram is not free, that's gone. It's DIEP, a DIEP graft. That is our answer here. Okay. I'm going to go back here for a second. What I mean by a free graft is that it is completely 100% removed from its blood supply, as you can see here in this image. And then it's going to be reattached to a new set of blood vessels and nerves with microvascular and micro surgical techniques to be placed in the recipient site. So that's why it's called a free graft. Pedicle, skate, and tram still keep their original blood supply intact. They're just moving that piece to another area, but they don't cut it off from its own blood supply. They actually just stay attached to its original blood supply. In a DIEP graft, it's going to be anastomosed to a new set of blood vessels. Okay. Number 11, a fat bone or cartilage graft harvested from the patient for implant during surgery from the patient. That is an autograft. It is from themselves. So if you guys can see this, I put this up here for your benefit. Please pause it if you need to write this down. But if the donor and recipient are the same person, that is autograft because auto means self. If it is a donor to recipient of the same species, so it's human to human, that's either going to be called an allograft or a homograft because allo means other, like another person. Homo means same, from the same species. So that's why allograft and homograft mean the same thing. Okay. And then for a donor to recipient of a different species, so an animal to human, that is either going to be called a heterograft or a xenograft because hetero means different, a different species, and xeno means stranger. So a stranger species, if that makes sense. So that all of these words are going to mean something in medical terminology. Just some of them are going to be two ways to say the same thing. Okay. Abnormally enlarged breasts in a female. That is the key. Female. Okay. So gynecomastia is gone because gynecomastia is enlargement of breast tissue in a male. Okay. Macromastia, micromastia, symastia. So micromastia is gone because we're looking for abnormally enlarged breasts. Micro would mean the opposite. So macromastia is going to be my answer here. Symastia can be a complication of breast augmentation surgery with implants, where the space in between the two breast mounds actually lifts and it creates a connection point. It almost looks like the chest wall has been completely lifted and the breasts are almost converging, coming together. So that's what symastia is. So macromastia is our answer here because macro means abnormally enlarged. Okay, 13, an abdominoplasty is often combined with which of the following procedures? Otoplasty is gone because that's, oto means ear. Rhytidectomy is gone because that's a facelift. So C is our answer, paniculectomy because of pannus. If you can see here, pannus is a fatty apron that typically will hang over the pubic mound. And there are various degrees of pannus grading, but a paniculectomy can also be indicated at the same time as an abdominoplasty to remove this fatty apron. Number 14, hair follicles and sweat glands rise from which layer of the integumentary system? Okay, it is not from the fascia. Fascia is the covering of muscles and organs, so fascia's gone. Hypodermis is gone, that's too deep. A is our answer. A is our answer because in the dermis, you can see here, I'm going to show you with my cursor. This is the epidermis. The epidermis is really, really, really superficial. The dermis is going to be a really thick layer. It is made up of two layers, but you can see the hair follicle actually begins here. The little muscle that is attached to every hair follicle. So whenever you get cold or get spooked and your hair stands on end, that's this little erector muscle here. And then you can see the eccrine sweat glands here, the sebaceous glands here. I don't know if I see any apocrine glands. I don't. But you can see where in this layer of the dermis, all of these structures arise from. And then number 15, which of the following tissue planes supports facial expressions by connecting the facial muscles to the skin? That is going to be what's called the SMAS, the superficial musculoaponeurotic system, SMAS. And during a facelift, we are going to dissect the SMAS free, pull it tight, reattach it a little bit further back and a little bit more superficial to create that lift. Okay. Plastic and reconstructive surgery intraoperative procedures review. You are going to do numbers 1 through 15 on your own. When I say pause, hit the pause button on your video player, answer those questions using our 50-50 and our test taking strategies, number 1 through 4. When you've completed all of the questions in the intraoperative plastic and reconstructive surgery intraoperative procedures review, go ahead and press play. We will review the answers together again. Okay, so on the count of 3, 1, 2, 3, pause. Welcome back. Okay, we're going to go a little bit more rapid fire this time. Okay, number 1, Mohs surgery is performed to treat which pathology? That is for malignant melanoma. You can see if you need to pause, you can kind of check this out, but how we're going to remove the layers bit by bit for Mohs surgery. Number 2, our answer, performing an augmentation mammoplasty, placing the implant between the breast tissue and the chest muscle. That is subglandular because we're going right in between the breast tissue and the muscle. If we were going underneath the muscle, that would be a different story, but we're not. We're on top of the muscle, so that is subglandular because glandular is referring to the gland of the breast. 3, our answer here is going to be a low transverse incision for a tram flap. You can see the tram flap there. Again, that is a flap that is still, it's called a pedicle flap. It's still connected to its blood supply. It's a little bit different than our DIEP that we talked about earlier. Number 4, what is a canthopexy? That is going to be A, our fixation of the point where the upper and lower eyelids meet. Often this is going to be performed with either an upper or lower lid blepharoplasty to tighten that space of the eyelid and remove any redundant skin. Number 5, dressing for a split thickness skin graft is going to be a stent dressing. Stent dressing kind of looks like either gauze that are moistened or cotton balls that are moistened that are going to be tied down usually by 6 points or 8 points with suture. Kind of makes it look like a little Hershey's Kiss. Adorable. Number 6, which of the following scissors would be used during a rhytidectomy? Those are our K facelift scissors. Number 7, the donut, lollipop, and anchor are incision patterns for a mastopexy. That is another way to say breast lift. And these are the incision patterns that you can see below. Number 8, liposuction begins by injecting tumescent solution. That is what this combined mixture is called. Number 9, the patient, when you're closing an abdominoplasty, you kind of want to flex the head up and the feet up. So you're going to go into what's called like a semi-Fowlers. It's going to look a little bit different than semi-Fowlers, but if you kind of see the inverted V, if you like sat them up, they would be sitting up. So that's why it's called semi-Fowlers, that flexing at the head and flexing at the feet. Semi-Fowlers. And that is to decrease tension on the abdominoplasty wound because you don't want it to pull apart and create like a hypertrophic scar. Okay, number 10, most commonly used technique in scar revision is a Z-plasty. Number 11, which muscle is incised and reattached during a blepharoplasty? Now this is the eye, so we're looking for oculi, orbicularis oculi. Okay. Okay, just a quick pause so we can go through and get our code. And I had it pulled up. Now I don't know where I've had it. Goodness me. Give me a moment. Where did my shot go? Aha. Okay. Sorry about that. A little technical difficulty. So this week's access code for Module 3 Path Certification Review Session Week 3, our access code is going to be 323524. Again, that is 323524. Okay. Number 12, which surgical skin prep solution must be used for an otoplasty? Because it's an ear procedure, no CHG at all, no alcohol, so it's going to be povidone iodine. Why is there not an answer there? I'm going to have to go back in and change that, but it is povidone iodine. That's our answer here because that is the safest for use around the external ear. You still don't want to get it inside the ear, but you don't want any CHG, no alcohol. So povidone iodine is our answer here. Number 13, Paget, Reese, and Watson are all types of dermatomes. Number 14, which of the following may be used to confirm perfusion of a transplanted DIEP graft? That's going to be your Doppler probe. And that's going to be used to confirm if the blood is flowing through the transplanted graft, because that's what perfusion means, that the graft is actually getting blood supply to it. And then number 15, during Mohs surgery, the specimen is sent to pathology immediately, and it needs to be a frozen section, so in a dry specimen container. So it's C. Okay. Intraoperative procedures review. We're going to switch gears into other surgical specialties, just questions that you might see that refer to the intraoperative portion of a procedure. I don't know why that was so hard for me to explain to you. So you're going to, again, when I say pause, you're going to pause the video, do numbers 1 through 15 on your own using our test taking strategies. When you have completed number 1 through 15, you can hit play again. We'll review the answers together as a group. Okay, last pause. Ready? 1, 2, 3, pause. Welcome back. Okay, which incision is utilized during an ACDF? This is an anterior neck incision because this is an anterior cervical discectomy with fusion. You need to know what ACDF stands for. We're going through the anterior neck here. Number 2, injection of an anesthetic into the intrathecal space, the subarachnoid space, is going to be for a spinal block. The reason it's not an epidural block, this gets people confused, so please pay attention. You can see here in the image that I provided, epidural, epi means above, dural means the dura mater of the meninges. If we're going into the subarachnoid space, that's underneath the dura, that is deep to the dura. The dura is superficial. So you would need to go deeper than an epidural block if you need to get into that intrathecal space. So if you've ever had any trouble between epidural and spinal and what that means, try to remember this image and you can see physically an epidural is going to go above the meninges. So it's not even going to go into the spinal cord proper here itself. It's going to go into this space right here. Okay, this epidural space. That's different than this spinal space. And that's going to have that cerebral spinal fluid. Okay, that's the difference. Please remember that. Number 3, this answer here, we're cross-clamping before an arteriotomy. So I always use the Vanilla Ice quote, ice, ice, baby. ICE, so it should be C. Yep, ICE. Yeah, so you're going to clamp off the internal carotid first, common carotid second, and the external carotid third. All of that clamping in order is to help keep the brain safe from any potential foreign object or broken off bits of plaque going up to the brain and causing potentially a transient ischemic attack. We don't want the patient to experience a mini stroke because we were messing around there. So that's why we clamp the internal carotid first, because that's going to go straight to the brain. So we want to clamp that off first. So just in case any bits of broken off plaque do move, they're not going to go up to the brain. Number 4, during an ORIF, which instrument is used first when placing a screw? That's going to be your drill bit. We're going to do drill, measure, tap, screw. Don't marry too soon. So we need to drill the hole first using our drill bit. Which self-retaining retractor may be used to perform a carpal tunnel release? That's going to be our HICE, that little guy. Sometimes in clinical, at least my hand surgeons sometimes used to call it a cricket, but its real given name is called a HICE retractor. Number 6, the S-mark bandage is used for exsanguination, almost like squeezing all that blood back towards midline. That's what an S-mark bandage is used for. We're going to use that prior to inflating a pneumatic tourniquet. Number 7, which is a non-invasive procedure. CABG is definitely invasive. EGD, invasive still. ESWL, not invasive. THA, definitely invasive. If you guys don't remember what these words stand for, coronary artery bypass graft, that's CABG. EGD, esophago gastroduodenoscopy, EGD, ESWL, extracorporeal shockwave lithotripsy, and THA, total hip arthroplasty. So you need to know your acronyms because these do come up. So ESWL is going to be our answer here. Because it's non-invasive, you're not actually putting anything inside their body. That's why. Number 8, this is a Marshall-Marchetti-Krantz procedure that is going to be a suspension for incontinence, urinary incontinence. So an MMK or Marshall-Marchetti-Krantz is going to be that vesicourethral suspension. Vesico meaning bladder, urethral obviously meaning urethra. Number 9, following the application of arch bars, you need to send wire cutters just in case they aspirate, or well, just in case they vomit, and you'd want to help prevent any aspiration. So you'd cut the arch bar, the stainless steel wires that are holding the arch bars together so they can eject that vomit and not breathe it in. Number 10, which of the following sutures is the primary choice when performing an arterial anastomosis? That's Prolene. Prolene is the vascular suture material of choice. Number 11, autologous graft, that would be utilized for an in situ CABG procedure. So an in situ means the vessel that we're going to use as a graft is going to stay where it is. So that is going to be our internal mammary artery. You can use a greater saphenous vein, but it's not an in situ autologous graft. That would be completely moving it from the leg up to the chest. So the internal mammary artery is already in the chest cavity, so you don't have to physically take both ends and move it. So that's why it's internal mammary artery for this answer. There's the right one and the left one. You can use either of those for an in situ CABG procedure. Number 12, to perform a transsphenoidal hypophysectomy, surgeon must gain access through the sella turcica, which is, I don't have an image, but the sella turcica is almost, it looks kind of like a saddle. And that's where the pituitary gland will sit within the sphenoid bone. So the sella turcica is a very important anatomical landmark for a hypophysectomy, which is the removal of pituitary gland, usually because of a tumor. You're going to do that through the nose. So it's transnasal, transsphenoidal hypophysectomy. Number 13, which procedure is performed to treat a detached retina? That is a scleral buckling procedure. That is going to help kind of patch the hole and keep the hole closed while it's healing. Number 14, stereotactic procedure, frameless stereotactic procedure. You need to put on what's called fiducials. And they kind of look almost like when artists that are rendering 3D objects sometimes put people in one of those green suits with a bunch of little white balls and they put them in front of a camera to do motion capture. That's essentially what the fiducials are. They're essentially motion capture or location capture devices that are going to be registered with the infrared camera, and they're going to be used to perform this navigation guided surgery. So that's what the fiducials are. If you can think of the 3D motion capture idea, that's essentially the same thing. That's what a fiducial is. And you can kind of see on image A here, these 3 fiducials that are here. There's more than just 3, but this is kind of just an image to help you guys kind of wrap your brain around what I'm talking about. So these little fiducials would get placed kind of like stickers all over the patient's head, potentially even their scalp, and then they will register those points on the infrared camera and layer those points over the CT or MRI that was previously taken prior to their procedure. So that's how navigation works. If you don't remember, please go back and look at navigation. It is something that comes up on CST exams. The number 15, the isolation technique would be indicated for which procedure? That's going to be for a Whipple because we are taking away a portion of the stomach and a portion of the duodenum. So we do need to do isolation technique for that. You're not going into the GI tract for an inguinal hernia repair. You're not actually going into the GI tract for a Nissen fundoplication, and you're not going into the GI tract for a splenectomy for trauma. So Whipple is the best answer here. And that's your Whipple procedure. Okay. I know this is a really long start, kind of par for the course with me for the very first video. They will get shorter. I promise. I try to stay within the 30-minute mark. So next week we'll go a little bit, I guess, less invasive. This is just a way for me to get you guys back on my page, get you invested in studying more for the certification exam. So if you have any questions, comments, concerns, please feel free to reach out to me. And I look forward to having you guys with me next week. Thank you again. Bye.